All right, so if everyone can take their seats, so welcome. This is our second portion of our hot topics. And essentially, so my name is Romy Yoon. I'm a anesthesiologist at Stanford. This is Dr. Michael Evans from Lurie Children's. And essentially, we're really excited to present to you part 2 of the hot topics panel for peds anesthesia. And the reason, again, why we call these sessions hot topics is that because these publications have really presented sort of great clinical impact or generate a lot of engagement or interest. And again, we want to reiterate that this is not necessarily the best papers or best abstracts, but these papers have generated some interest that these editors have selected for you today. And again, the format of the session will be the 2 presenters will go first for 25 minutes, and then at the end, for the last 10 minutes of the session, we'll field questions. You can also submit your questions on the My Mobile app through the ASA as well, and we'll take a look at those as well. So without further ado, our next presenter is Dr. Jim DiNardo. He is a professor of anesthesia at Harvard Medical School, also a senior associate in the Division of Cardiac Anesthesia at Boston Children's Hospital. He has also been the past president of both the Congenital Cardiac Anesthesia Society, also the Association of Cardiac Anesthesiologists. And today he'll be presenting some articles that he selected from ANA, or Anesthesia and Analgesia. So please welcome him.
Alrighty, let's get started. I have nothing to disclose. All right, so first I'm going to talk about a topic that fortunately or unfortunately has got a lot of attention recently, but this is a really, really great article. These authors took the time to really codify the way we think about children with autism, and then to also codify what sort of strategies we have to make their transition during the perioperative period a little bit easier. So, so you can see here that the authors have divided their evaluation of the child with autism up into 4 categories. So the first thing you want to think about is, what is their sensory status? Are they sensitive to tactile stimulation, to light, hyposensitive to sensation? You can see them all. The next thing to think about is communication. Are they verbal, nonverbal, or do they communicate in some sort of unconventional ways, right? These are all things that you would help establish with their family. Do they understand the purpose of surgery? Do they understand the roles of the people in the team? And then in the sensory category for the pharmacologic approach, you want to think about, will the patient take PO medications? Can they take their pills? Can they take liquids? Can they take both? Do they have any comorbidities that might affect pre-medication, such as a G-tube or central access that might offer you another route? Think about the intranasal route. And then finally, you need to evaluate behavior. So how do they respond to stress? Is there going to be yelling, hitting, attempt to escape? How do they calm down from stress? What prior pharmacological and non-pharmacological strategies have been used for surgery? So a careful conversation with the family about what's worked and what hasn't worked in the past is very useful. And then here, I think, is really the crux of it. This is where the authors really make a substantial contribution to things. They divide the patients up into categories here based on mild, moderate, or high severity. And then break those down into communication, sensory, and behavioral components. And as you can see here, a child with mild symptomatology may be able to communicate directly with you. They may be able to be in a standard pre-op area. As far as behavior goes, they may have relatively normal responses to being upset. And then in the moderate category, you can see that things become a little bit more challenging. And finally, in the high severity category, particularly as regards behavior, things can be extremely challenging. So again, I think this is a really valuable education tool, not just for anesthesia staff, but I think for nursing staff. This is the kind of thing that I would see people using as part of their protocols for dealing with children with autism in the preoperative period. And then finally at the bottom, you can see the recommendations for typically used doses, which is very helpful. I think that part for most of us is pretty straightforward, but again, I think for nursing and ancillary care people, that information could be very, very useful. Okay. Next, we're going to talk about adherence to postoperative nausea and vomiting guidelines. This is a really interesting study out of Israel where the authors looked at the rate of adherence to postoperative nausea and vomiting guidelines in their hospital in a cohort of about 4,000 patients. And what they found, and again, we got into this conversation earlier about, how do you define postoperative nausea and vomiting? Well, in this study, and you could be critical of this, they defined it as any episode in the recovery room or in the immediate postoperative period where the patient received doses of antiemetics, right? That could be a problematic definition, but it's the definition they used. And what they found, if we jump here, this was their institutional protocol, which is basically the protocol that has been recommended by multiple journals and is generally, considered to be the method of evaluating risk for postoperative nausea and vomiting and then prophylaxis. It's pretty standard. And this is the protocol that they utilized in their institution. What they found was, despite this well-established protocol, that adherence to the protocol, right, based on risk stratifying your patient with number of risk factors was only about 40%. Which is pretty depressing, actually. Right, so you have the protocol, you identify the risk factors, there are clear treatment guidelines, and even despite that, only 40% of the people adhere to the guidelines. The other thing that's interesting, and you can see this is the multivariable analysis in terms of risk factors and the distribution of the patient population. The other thing that's interesting about this study, and the other thing that you have to keep in mind, is that they found that the overall incidence of postoperative nausea, vomiting in the immediate postoperative period was 1%. That's very low. And in the entire postoperative period, it was 3.8%. That is also extremely low. So you have to think about what does that tell you? Does it tell you that, well, even though only 40% of the people adhered to the guidelines, that adherence resulted in a relatively low incidence of nausea and vomiting? That's conceivable. Or that more likely their definition of postoperative nausea and vomiting based on triggering administration of antiemetic treatment doesn't really cover what most of us would consider to be the incidence of postoperative nausea and vomiting, right? Some people consider retching, some people consider actual emesis, so you have to take that with a little bit of a grain of salt. But I think the important thing about it is, if nothing else, there's a very clear delineation of what should be standard prophylaxis for postoperative nausea and vomiting based on risk factor stratification. And then I would invite you to read this editorial. I don't have any other part of it here, but it delves into some of the issues that I've addressed here and written by some very knowledgeable people. Okay, so how many people here use fibrinogen concentrate? Anybody? A couple. Versus cryo. So this is a little bit of a debate, in at least in my world, in the cardiac anesthesia world, where we administer large truckloads of cryoprecipitate to little babies, and in Europe there is no cryoprecipitate, so fibrinogen concentrate is very commonly used. We now have fibrinogen concentrate available in the United States. It's readily available. And the question that these authors ask, and this is an ex vivo study, right? So they're doing their cardiac surgery on neonates. They're using their standardized protocol, administering antifibrinolytics, and then drawing blood from the patients and doing this ex vivo study. I'll show you in a minute what they're looking at. And this group has been the group from Atlanta has been very active in addressing, neonatal clot formation, the combination of neonatal fibrinogen with adult fibrinogen and the strength of clot when you mix those two things in their previous research. But the point here was to look specifically at the resistance of clot to fibrinolysis if you use cryoprecipitate versus fibrinogen concentrate. So a very directed question. And what you can see here is they use this plasmin overlay degradation assay. So basically they have this matrix where they can take the patient's blood and then specifically add plasminogen activator to a sample and induce fibrinolysis. That in and of itself is pretty interesting and pretty cool. The thing that's interesting about this is what they found is that there was really no difference in the ability of babies who receive fibrinogen concentrate versus those who receive cryoprecipitate to withstand the amount of fibrinolysis that occurs when you add a fibrinolytic agent. Okay, I mean, that's interesting. That's a you could say to yourself, well, that's a pretty limited analysis of things. But I think the point here is that, we have people trying to apply technologies to ask difficult questions because we're beyond the point of just deciding whether you're going to use fibrinogen versus fibrinogen concentrate versus cryoprecipitate, right? We need to be a little bit more insightful about how we make these choices. So one of the things you see here, and if you're not really into this, it would be hidden in this study. But if you look at these differences between fibrinogen concentrate and von Willebrand's factor and the amount of thrombin that's formed, one of the things that you notice that is a significant difference between the cryoprecipitate babies and the fibrinogen concentrate babies is the concentration of factor 13. And, unless you're really into coagulation, factor 13 actually is a pretty important factor. It gets involved after the clot is actually formed and is a major component of clot strengthening. So without factor 13, clot is extremely vulnerable to dissolution. And there are a whole bunch of adult studies that show that, postoperative bleeding in cardiac surgical patients is directly proportional to the concentration of factor 13 that's around. So the one advantage that you get here by using cryoprecipitate is that you get elevated levels of factor 13, which can be, and fibronectin, which is also another component in cryoprecipitate that's not in fibrinogen concentrate. So that there may be, if you will, a hidden advantage to giving cryo versus fibrinogen concentrate, but it's just something to think about. Okay, and then there's an editorial that accompanies this. The main reason for this editorial, and I think it's worth reading, is it does a really nice job of kind of summarizing the work that this group has done looking at neonatal clot formation, and in particular things like what happens when you mix neonatal fibrinogen with adult fibrinogen, right? I mean, that's not something you'd necessarily think about, right? Because when you do that, when you give cryo or when you prime the pump with adult FFP, you're mixing things. And I'll leave it to you to, go down that rabbit hole. But it turns out that that actually isn't such a great idea. It may be a necessity, but the fact of the matter is there are completely different clot kinetics between a baby and adult and a baby and adult with a mixed product. Okay, and then finally, because there are always very, very smart people around, this letter to the editor regarding this study makes some very good points, which is, hey, this fibrinogen overlay thing is really cool, but it ain't physiologic. And you did this study with patients getting an antifibrinolytic agent, and how on earth did you know how much of a fibrinolytic agent to add to this assay? And so, although we congratulate the effort, we're underwhelmed. Interesting to read if you're at all interested in this kind of stuff. Okay. A lot of talk about pediatric patient blood management. This is a prospective paper which involved surveying the membership of CCAS, the Congenital Cardiac Anesthesia Society, about issues concerning blood management, components of blood management. And like every survey, right, what's the response rate? Like 10%. I mean, that's what you get when you do a survey. And that's what happened here, but, it is what it is. And what you see, just quickly, the results here, we're asking this group of people, which of these components of patient blood management they're involved with, and across, multiple institutions. And you can see that, a high percentage of institutions have point-of-care testing or viscoelastic testing to guide transfusion. Anemia assessment is okay. Anemia on a CBC triggers a workup, right? The blood management people would say that's an area where we could really make some headway in patient blood management, which is if you identify a patient proactively that's anemic, you probably ought to figure out why they're anemic and decide if there's some sort of reversible cause, right? Iron deficiency or would be the most common, but some other reason that they might be anemic. And then, is there a standard intra-op transfusion algorithm? Well, almost 40% of the people. That's a little bit disappointing. It also is interesting given that if people are doing, the testing, why aren't they developing a protocol to use it? And then I think the other thing to think about, and the one that I have the least confidence in, I guess, would be ICU transfusion algorithms. As someone who worked in the cardiac ICU for like 20 years, and I don't mean this in any bad way. I'm not really sure that most of the cardiac anesthesiologists whose work was limited to the OR actually had a very good idea of what the transfusion algorithms in the ICU were. But anyway, so the point here being, if you would all believe that pediatric patient blood management is an important thing, we have a long way to go. I mean, people understand it, they recognize it, but we're not doing a very good job of actually adhering to the principles that have very clearly been delineated. All right, so non-invasive cardiac output. How many people have Nikon Coden monitors? Anybody? How about Philips? Okay. So that's interesting. I wonder what people have. Well, Philips has completely given up on product development. They have no interest whatsoever in any R&D. And so a lot of programs are, moving away from Philips because they're not doing anything new and they're not doing much product support. But so Nikon Coden has been a very active monitoring company. And they've been putting out all sorts of modules to add to their basic monitoring. This one happens to be non-invasive cardiac output. In this study, basically what they did is took a bunch of kids having non-cardiac surgery, used this echo monitor, and then compared the output measured by that monitor against transthoracic echo measurement of aortic outflow tract, which is a pretty well acknowledged method of measuring cardiac output, right? If you know the velocity time integral across the LV outflow tract and you know the cross-sectional area, you just do a little multiplication and you can get a cardiac output. And so the technology, here's what's appealing about the technology. All you need is an EKG and a pulse oximeter, which makes it quite a bit different than a lot of the other non-invasive cardiac output monitors that are out there, right, that require an arterial line. There's a lot of non-invasive cardiac output monitors that involve measurement of expired gas, end-tidal CO2. You can, estimate cardiac output by doing some manipulations of measurement of end-tidal CO2. So this one's appealing. So basically, what you're looking at is pulse wave transmission. So just a couple of things, right? If pulse wave transmission time is just how long it takes for a wave of blood to make it from your heart to the periphery and be reflected back. Pretty simple. The speed at which a wave of blood will propagate is basically based on two things: the volume that you're throwing down the vasculature and the compliance of the vasculature. So, grandma with a lead pipe aorta and a pretty big stroke volume is going to have an unbelievably fast pulse wave transmission. Whereas a little baby with an extremely compliant aorta, even with a big stroke volume, is going to have a pretty slow pulse wave transmission. But the way they measure pulse wave transmission is using the upstroke of the pulse oximeter. Actually, they use the first derivative, but that's not important. And then, of course, there's some mystery, proprietary algorithm, right? Because you don't know what the compliance of your patient's aorta is. And what you really want to know is the stroke volume, and then you can multiply that by heart rate, and you'll get a cardiac output. But anyway, whatever the algorithm is that corrects for the compliance of the aorta appears to be pretty good, because if you look at the correlation between directly measured cardiac output and the device, it's pretty darn good. And you can see that both in the correlation coefficient and in the Bland-Altman analysis over to the other side of it. And then, if you're really serious about this stuff, this is called polar analysis, where what you're analyzing is not only the correlation between the cardiac two cardiac output measurements, but the ability of the device to detect changes in cardiac output. And the way you do that is you do this thing called polar analysis, and you decide that they have to be within a 30% arc range is the standard you use for what's a good cardiac output measurement. And you can see actually that the device does quite well. So there may be some enthusiasm for that. Like all of these things, the proprietary algorithms are all a big mystery. You're never going to get to know what that is. But at least for this device, it seems to be pretty reasonable. Okay, so let's talk about Sugammadex. This is a really interesting study. This is like almost 100,000 patients across 30 institutions. And what we're looking at is what are the factors that are associated with whether you administer Sugammadex or not. And so in the entire study cohort, about 50% of the patients got neostigmine and atropine or glyco, and 50% got Sugammadex. That's pretty interesting. What's more interesting is that after you analyze all the different factors, patient age, how soon after the last neuromuscular blockade agent was given, comorbidities, all that kind of thing, what you find, and I'm just showing you the age distribution here, I'm going to do that first, across all these institutions, if you look at the age groups, and the dose of Sugammadex it's given, right? You can see that most of them are clustered around what we would all consider standard doses. What you find is that the choice to administer Sugammadex is basically institution and practitioner associated. So if you look at the percentage of cases receiving Sugammadex anonymized by the institution on the top screen, you can see there's some institutions that give it to everybody, there's some institutions that don't give it to anyone. And the same is true by attending. If you look at the bottom scale, you can see some attendings never give it, and some attendings give it to everybody. So, what do you make of that? I'm not sure. Let me go back. Clearly, each of us as individuals has our own threshold for using the drug. I know probably among the older practitioners, there's going to be a higher percentage of people who use Sugammadex sparingly, and among the younger practitioners probably use it more commonly. Is that a good thing or a bad thing? I don't know. I mean, I will admit that probably 3 or 4 years ago, I said, okay, I'm willing to do a case where Sugammadex is used rather than neostigmine and glyco and atropine. But I personally am never going to have my thumb on the syringe of Sugammadex. Well, unfortunately, that didn't play well going forward. So even as an older practitioner who was perfectly content with neostigmine and glyco, we've moved to, I myself have moved to using Sugammadex. And I will admit, in vulnerable neonates where we're using, rocuronium muscle relaxation, I must admit I would jump on using Sugammadex myself. All right. This is a pretty hot topic. We're talking about regional anesthesia for cardiac surgery. Do any of you guys do regional for your cardiac surgical patients? Yeah. It's really interesting. We do it at our place, and most of the older cardiac anesthesiologists are like, yeah, right. It doesn't make any difference. Locally infiltrate, they do fine. We can still extubate them at the end of the case. And the youngsters are much more about regional blockade and adding regional blockade. So we've had this, we're slowly but surely moving to everyone getting some sort of regional blockade, but it's been a little bit of a culture war. So the idea here was to do superficial pectoral type, peristernal pectoral type blocks and a tap block. And some people believe that, you know, for the mediastinal chest tubes that are down lower, that you really need a tap block to cover that distribution. And you could argue that that's a reasonable thing. And what they looked at is this cohort of relatively low-risk kids having ASDs and VSDs, and regional anesthesia versus just local infiltration. You can see, you know, the difference between the two groups. They're pretty similar here. They're looking at the ASMD, which is another way of determining how comparable groups are. And what you can see here is that the one metric that was different between the two groups was the amount of opioid use in morphine equivalents per kilo in the hours following surgery. And if you look at the difference in pain scores over time, the regional group at the beginning had lower pain scores, the effect of which dissipated right by 30 or 40 hours post-op, which makes sense. I mean, the local anesthetic is going to dissipate by that period of time. Let me go one further here. And then, of course, right, here's where we get to the nitty-gritty, and this is where the people who are not, you know, on board with regional anesthetic techniques are going to say, so what? Because if we're going to look at outcomes that, you know, people might consider meaningful, there really wasn't a big difference between the two groups, which is about what you would expect, I suppose. The question is, you know, is the reduction in opioid use and the lower, slightly lower pain scores in that interval of time a meaningful enough outcome that you would pursue regional anesthesia versus local infiltration? But if you're going to start looking at things like time to extubation and hospital stay and that kind of stuff, there's just not going to be a difference. Okay. Finally, this is just something to think about. It kind of shows where we're, the ability we have now with advanced pharmacokinetic analysis to do some interesting stuff. This is a group who identified some patients who have a loss of function allele that alters the hepatic metabolism of morphine. And what they did is they took these data sets and did some simulations and analyzed this stuff, and were able to show both experimentally and practically and able to predict this actually, that the patients with this loss of function gene would have a difference in the way they metabolized IV morphine versus oral morphine. With the point being, you know, as we get more sophisticated at being able to identify different genotypes, you could actually make the argument that you could tailor your, you know, drug therapy based on specific allele gains or losses, which is pretty interesting, actually. But just something to think about. Thank you.
All right, and then our final speaker for today is Dr. Alan Simpao, who's an associate professor of anesthesiology and critical care at Children's Hospital of Philadelphia, and University of Pennsylvania. He's also the Associate Director of Anesthesia Services at CHOPS, King of Prussia Hospital, Associate Division Chief of Research and Co-Director of the Biomedical Informatics Program. He was the immediate past president for STA, or the Society for Technology in Anesthesia, and currently is the Associate Editor for Anesthesiology, Pediatric Anesthesia, and Editor-in-Chief for the Journal of Medical Systems. So today he'll be presenting articles from the Journal Anesthesiology. Let's see. Yeah.
Thank you. All right. Thank you, Romy, for the kind introduction. And I'm honored to be here, as always. Highlight of my year. I'm Alan. I'm going to be talking about articles from anesthesiology. They are the stars of the show. So let me try to proceed. Yeah, so hot topics and the standard disclaimer. No offense to anybody if I didn't include your article. Get right to it. And now in the interest of time, I can speak quickly, which is usually something I have to stop doing in a presentation. But adverse events in Japan, right? The JPedia study. I also have QR codes. A lot of these articles are open access. If you have any trouble accessing any of them, I will surreptitiously send them. Don't tell Wolters Kluwer. All right? So in Japan, they performed this prospective study of airway events using a standardized collection system. And I'll get to those data elements shortly. It was across 10 hospitals, a mix of both pediatric hospitals and adult pediatric mixed hospitals. And you can see photos of them there that I scoured from the internet. But they pay homage to Apricot and PDR when you think about airway event databases or registries, right? One of the first things that come to mind are all the fruit registries from fruit-related from Europe. And they acknowledge them, but also say that, you know, those registries or the studies were not designed specifically for airway events or for a bunch of critical events, but not just, no offense to some of the authors who might be in this room. And then PDR, most of us from the SPA know and love, mind plenty of studies from that, right? But that's also the DI, difficult intubation. So focused on difficult intubation patients, not all comers. And that's what they did in this study. So JPedia, looking also at patients primarily in Asian regions, which has been understudied in airway management research. They wanted to look at adverse events, including desaturation and various adverse events that I'll get to in a little bit. But they included almost all comers aged less than 18 years of age, where there was a tube, supraglottic airway, or even a surgical airway in the OR. And anything outside the OR they excluded. And also if they were previously enrolled in the study, trying to get primarily single representation in the study as much as possible. You can see all the different data elements they studied. I will definitely not read all these one by one. But instead go right to the results. Because they were going to try to capture all the data they could about the patients, the devices, and then all the different complications. So the different adverse events by age group, they found across 17,000 airway management procedures in this study period, primarily in the neonate group. And talk about Andrew, again, kind of Andrew Davidson leading in with some of the things. What are the patients who are most at risk when we take care of them? Where are we most at a loss? I believe when we're taking care of neonates, that was borne out in this study. And then incidence of respiratory adverse events by age group. You can see all the different respiratory adverse events they list here. They had a 1.1% rate. Again, all comers, not just difficult intubation patients. And they also stratified by the different age groups. You can see neonates, again, with the highest incidence of respiratory adverse events as well. Interestingly, vomiting with aspiration. You can see that brown block right there, highest in neonates. Has that been your experience at your institution? Because for us, it's always the teenagers who sneak, barbecue until midnight and then have their first case the next day. And I actually stopped at midnight. No, it's interesting. So that's what they observed in Japan, though. Right? Vomiting and aspiration in neonates. And then laryngospasm highest in preschool children, not neonates. So I think this highlights sort of the importance of looking at different populations that might change your thinking about how the regional cultural location differences in airway management and airway experiences. They have the incidence of desaturation by age group, again, as expected. Neonates in Japan, no different from those studied in Europe and in the US. And the risk factors, younger age, things we've heard about before, but also still borne out by the study in Japan. So management outside of the OR in the off-sites, craniocervical surgery, and then having more difficult airway features. Interestingly, factors associated with decreased odds of events, so supraglottic airway device placement, and then muscle relaxant use, which if you look at the PDR articles, I'm always pushing for early and positive muscle relaxant use when securing the airway. A lot of limitations that they admit to. Reporting selection bias, that's where they had to, because it's self-reported data, also the Hawthorne effect when you're recording somebody, the missing data whenever you're self-reporting, those sorts of things you would expect in a study of this nature, but no real huge red flags. So in summary, the JPEDIA study, coming out of Japan, again, 10 hospitals, was able to determine some adverse event and desaturation incidences. And I encourage you to look at the editorial that comes along with this too. It frames it all very well and does mention things like apricot, nectarine, and PDR. So speaking of airways, well, we have to reverse the muscle relaxant we just gave to secure the first attempt. So let's talk about now about the Sugamidex for reversal of neuromuscular blockade in neonates and infants. How many of you are giving Sugamidex to your neonates and infants, much like we just heard about? All right, good. Well, now we have a study to actually support some of that, what we've actually been doing off-label. It's great. So this came out, randomized, multi-center trial. You can see 23 centers. Most of the authors are actually from Merck, but two of them, one from UT Health Houston, and then also the one from Antwerp. And the primary aim and endpoint, hopefully you're managing your neonates better than ChatGPT does. But you can see, evaluating the efficacy and tolerability of Sugamidex in children younger than 2 years. And their endpoint was time to neuromuscular recovery. And then they divided out in part A, this was just a pharmacokinetic study. So 4 age cohorts, and these are all patients under 2 years of age. Gave them rocuronium, vecuronium, and then gave them moderate block, and then gave Sugamidex 2 milligrams per kilogram, 4 milligrams per kilogram, and then took blood samples for the PK analysis. And they used that to see if they had to adjust the doses they were giving during Part B, which was the randomized control trial, with 3 groups. So the 2 milligram versus 4 milligram doses of Sugamidex, and of course you have to include neostigmine, again, as a comparison group. Thankfully, in Part A, they found they didn't have to adjust the doses for Part B. And then, as you probably have experienced in your own practice, Sugamidex reversed moderate block faster than neostigmine, and at 4 milligram per kilogram doses was effective at reversing deep neuromuscular blockade. Here are the Kaplan-Meier plots. In green, it might be a little bit difficult to see, I'm sorry, but take my word for it, the left one, that on time to recover on the x-axis, shorter time to recover overall with cumulative recovery on the y-axis is Sugamidex and then neostigmine. And this is, and then when you add the 4 milligram per kilogram dose, same sort of pattern that you would like to think happens when you're giving Sugamidex to your neonates. They also observed similar rates of participants with 1+ adverse events. When I shorten this, it definitely sounds like broken English, but basically, adverse event rate was similar, and nobody died that they could attribute to Sugamidex or to neostigmine. Limitations of this study, I don't know how you're monitoring neuromuscular blockade in your neonates and infants when anesthetizing them, but as you can imagine, in this study also everybody's pretty bad at it and only used accelerometry and not electromyography. Very few participants in the PK portion, so there's limited precision. It was not a dose ranging study. That came up earlier, I think, I don't know if it was in Laszlo's talk or in Andrew's, but trying to find out how much we should be giving to neonates and infants, not just how does our standard dose do in neonates and infants. This was not, this study was not designed for that. They didn't look at total total rocuronium or vecuronium dose. And they said no deaths, but that's, you remember, it's a very small study, just a little over 100 patients. All right, we have some support for what we've been doing all this time with Sugamidex in neonates and infants, and it compares favorably with neostigmine. Again, a very nice editorial. Encourage you to take a look. Again, now we're going to move over from Sugamidex and neonates and stuff to anesthetic neurotoxicity. Again, hopefully you are anesthetizing better than ChatGPT. And if you are worried about neurotoxicity, you're not pumping 2 different intakes into your patient's face. All right, so This is a hot topic for anesthesiology. I couldn't fit them all on one, well, I could fit them all on one slide, but I'm trying to fit them all into one talk. I'm going to go very quickly through them. This is especially because Andrew's not here for this one. So this T-Rex trial, looking at low-dose sevoflurane, dexmedetomidine, and remifentanil, right? So you try to reduce exposure to sevoflurane versus just standard sevo. And this is also, the interesting about the T-Rex trial is that it's a longer exposures, right? Over 2 hours of general anesthesia, unlike other studies where it's reported, less than around 60 or 70 minutes. And this was a preliminary analysis where they looked at secondary outcomes, comparing that low-dose sevo regimen and standard-dose sevoflurane regimen, standard-dose anesthetic. And they saw more intraoperative hypotension in sevoflurane patients, but more intraoperative bradycardia in the low-dose sevo dexmedetomidine patients. Interestingly, light anesthesia episodes came up as very significantly greater in the low-dose sevo group, which they attributed to unfamiliarity with the protocol, and noted that actual protocol abandonment, so people going from that low-dose regimen to standard dose, was only 1 out of those 89. So while it was light anesthesia, that the anesthesiologist or whoever's in the room had to do something about it, they didn't actually have to abandon the protocol. And all the important stuff like, morbidity, mortality were similar. Still okay with time. All right, good. So these authors concluded that in the T-Rex trial, the 2 arms are broadly clinically similar in outcomes, and there's no clear evidence. So they basically didn't want to find that they didn't find that their approach caused significantly greater hypotension, bradycardia, and all those other bad outcomes. Let's now move to the middle article here. Again, Andrew left already, but this is one of his studies. And this comes out of the gas trial data. So when we talk to parents about anesthesia doesn't melt their child's brain, we probably don't want to direct them to this article. And again, Andrew's not here to answer for it. But the gas trial, if you recall, was published. The results were published in a very fancy journal years ago. But it was multi-center, 28 hospitals, and it was either spinal or general anesthesia for inguinal hernia repair. All right, published in the Lancet. You might have heard of it. Both in 2016 and 2019. So very impactful research at both the 2- and 5-year outcomes. What this study was a secondary analysis. So 2 or more general anesthesia exposures versus 0 or 1. How are the neurodevelopmental outcomes in those patients? Based on the full-scale intelligence quotient of Wechsler at 5 years, so the 5-year data, not the 2-year. And unfortunately, they found in 2 or more general anesthesia exposures with an N of only 141, the scores on the full intelligence scale was actually approximately 6 points lower and significant at 0.01 compared to the comparison group of 0 to 1. They also performed a sensitivity analysis of 1 to 0 and I think 2 to 1 and things of that nature, and it just kept lighting up. So they concluded that multiple GA exposures before 5 years of age in the secondary analysis of the gas trial database was actually associated with decreased performance in a full-scale intelligence quotient. But there's a whole paragraph I encourage you to read if this is disheartening about where they say there's a small sample size. There's plenty of unadjusted residual confounding. There are a lot of shortcomings so that you can still feel good about yourself as you've anesthetized children before the age of 5. Next is the now moving from sort of older ongoing studies to a new one, effects of dexmedetomidine and remifentanil on neurodevelopment of children after inhalation anesthesia. And this was actually a randomized clinical trial. And that sounds kind of familiar, right? We just talked about the T-Rex study. And that's actually kind of similar to what they did here. So prospective double-blind, 343 children less than 2 years, and only single surgeries. And this was done in Korea. They wanted to assess intelligence, behavioral outcomes, and sevoflurane alone, or sevoflurane plus dexmedetomidine and remifentanil. But a little bit of a change in their approach. They used a different assessment tool, the Korean UC Child Behavior Checklist. They also had secondary outcomes. And this is similar to the T-Rex study where they are assessing things at 28 to 30 months, but they actually plan to do the final analysis and assessments and everything in 5 years. And the anesthesia protocol is here. You can see dex versus control, so saline versus dexmedetomidine and remifentanil. And what they found was, in this study, as they titrated to a BIS of 40 to 60, patients in this in the dex group received or needed less end-tidal or less sevoflurane, not end-tidal, had lower end-tidal sevoflurane readings to maintain the BIS at 40 to 60. And then their IQ scores at this point of this assessment, not significantly different across the two groups. And all the different limitations, including using BIS to manage the protocol, means that anesthetic management is really heterogeneous. And also choosing 6-point IQ difference, the study is powered for that. So if there might be 3 or 4 point difference that's not being detected. And they still already have some missing follow-up data. So at this point, this study is, again, a prospective trial similar to T-Rex. And I like the editorial here that Andrew wrote. I didn't just pick all these because I thought I was going to see Andrew today, but really it just happens to be. Second randomized trial to suggest you shouldn't change your anesthetic in infants to avoid neurotoxicity. But yes, no differences in neurodevelopmental outcomes, and we're really waiting for the 5-year endpoint. There was a nice infographic on this also, thanks to Dr. John Wander and team. And this was also touched upon briefly earlier, the development of the pediatric scale for quality of recovery. So there are quality of recovery scales for adults, right, but not for children. And this is what this team, this group did out of Queensland Children's Hospital, Royal, and then also CHOP and Boston Children's. And they did a ground-up mixed methods development of a pediatric recovery questionnaire, try to develop a scale to assess the quality of recovery in pediatric patients. So you get your patient to recovery, how'd they do? It's like thumbs up or thumbs down, right? Are they screaming or not? I think I did great. They woke up wondering when they're going to have surgery. Well, let's get, the goal of this was to actually get some metrics that you can actually, quantitative metrics to quantify how your patient did in recovery, instead of just a thumbs up and a self-pat on the back. And talk about a top-down. So they did a literature review looking at all the existing tools to measure quality of recovery in children. And then also did a ground up, asking patients, their parents, anesthesiologists, surgeons, what's important to you in a patient's recovery? And then meeting in the middle with a Delphi panel. They cut back from 216 items that were identified down to just 50. And then also whittled those down based on these semi-structured interviews, create a questionnaire, and then administer it to over 1,000 children and families in the US and Australia. And distill everything down to a 20-item PEDS quality of recovery scale that includes physical and psychological recovery domains. And this just shows them, I'm not going to read them all, but it divides them into physical and mental well-being, and they're the kind of things you would think about. It was harder for me to move around, I was more forgetful than usual, I had vomiting, I felt really worried. And the overall score ranges from 20 to 100 as you administer these, and the responses are things like always, often, sometimes, rarely, or never. And this does not do justice to the amount of work that went into creating this 20-item questionnaire, but hopefully this will help us to quantify and study how well our patients, our children, are doing in recovery in a way that we've already been doing for years in adults. Move now to breath analysis of propofol and associated metabolic signatures. I think we all give so much propofol, we probably have some in our breath. But the secondary electrospray ionization, high-resolution mass spectrometry, try to say that 10 times fast. So 10 patients, a pilot study, and looking at propofol anesthesia, and they took pre and post breath and blood samples. And this was done in Switzerland. And they took advantage of the fact they have this device there, and they've been studying other pharmacometabolomics via breath analysis. And they thought, hey, what about propofol? So they did it. It's pretty cool. What they did was place an IV, sampled some breaths, induced, intubated, placed a second IV, sampled, sent it off, and then also studied it using this mass spec. And it's a very busy slide, but I think for most of us, that orgo on the left side is just a blob, so we really just focus on the graph on the right. So 2,6-isopropylphenol, which is propofol on the top left, and its metabolites. And you can see in the graph what they have here. The top orange is breath propofol, you have breath quinone, and then serum propofol. So they're actually able to measure and show the association of these breath-derived features in their sampling, in the mass spec, that were associated with serum propofol concentration. So the top left is propofol, and you can see very strong association between breath propofol and serum propofol using this technique. So you wonder, when is this going to show up in our machines, and how much is it going to cost? And they do talk about this, that there is a proof of concept, but it is not widely adopted yet or implemented. This is a really nice metabolic cascade that shows, interestingly, of all of this, it's very busy also, I'm sorry, I'm that guy. But the sevoflurane that you see, it showed up even in patients who did not receive sevoflurane. So the authors suggest that possibly that's just residual sevoflurane in our machines and circuits that ended up, because the mass spec is so sensitive, that they were able to find a signal for sevoflurane even in patients who did not receive it. It's interesting when we take care of malignant hyperthermia patients, right? So, interesting. So, breath analysis of propofol, on-site, et cetera, and so forth. Breath pharmacometabolomics. You can capture this correlation between breath and serum propofol. And then that big metabolic map was showing different things being upregulated and downregulated in response to anesthesia and surgery. So you can actually even see like changes in these markers for metabolic stress. I have to pick this one, PD Crisis 2.0, because of SPA and also as one of the originators of PD Crisis 1.0. It's nice to see how much better PD Crisis 2.0 is and people actually doing stuff with it. So 51 pediatric anesthesia fellows across 4 hospitals, but one was kicked out because they randomized wrong. Sorry, Children's National folks. Thanks for trying. Evaluate whether Jetson time knowledge with PD Crisis 2.0 leads to improved testing outcomes. How many people think if you have an open book test with PD Crisis 2.0, you do better than without? All right. Thanks for the folks who just raised your hands because it was a dumb question. But crossover design, but to study it was actually pretty cool. They used even and odds for app and no app, and then they reversed it as they were randomized, the fellows, with the different case scenarios. You can see case scenario 7 is hypertension, which the rest of these all cause, like air embolisms and bronchospasm. And you can see the results. You hear all the box plots. On the left of each of these rectangles is app. On the right is no app. And percent correct is the y-axis. So what you would expect to see is in the app side, over each of these rectangles, app higher than no app, which it is for all of them, and all of them are significantly different. So, fellows were significantly more successful describing the management of pediatric critical events when using PD Crisis 2.0 versus not. And does that translate to then fellows are more successful managing these events when using PD Crisis 2.0 or not? That is not studied or proven here, but at least they can go through and talk and reason things out and what they would do better than without. Finish with a just quick blurb about the Pediatric Regional Anesthesia Clinical Focus Review. And this is by one of the giants in the field, right, Dr. Marhofer, who went through and he and 2 other colleagues went through all the different blocks, ultrasound anatomy, things of that nature, drugs, includes some nice images and examples. Oh, sorry. So I encourage you, this is a clinical focus review. If you want to just like a nice condensed form to share with colleagues or your trainees about practical pediatric regional anesthesia. All right, yay, my fast talking did work and help out. All right, thank you very much.
2.5 minutes to spare. That's fantastic.
We have questions?
Can I ask a question? Hi, Bridget Pierce, University of Michigan. It's for Alan. And the JPDS study for the neonates, you referenced aspiration, but a big chunk of that was esophageal intubation. Did they talk about the use of video laryngoscope for neonates?
That was one of the shortcomings they mentioned in their approach is all of the device, first, second, third attempt, that sort of stuff was not captured as far as I know. So that's a great point. Thank you for raising, yeah.
Really a standard of care for a neonate.
Exactly, and that's borne out by the PDR studies and other, so the VISI trial, things of that nature that support, yes, video laryngoscopy over fiddling around with the DL. Thank you for raising that point.
All right. Other questions? I don't think we have anything submitted on our My Meeting.
Nothing online.
I have a question, actually.
Oh.
For the study that you mentioned where multiple GAs under the age of 5, where they showed potentially differences in points in their neurodevelopmental IQ scale, did that generate any interest outside the media?
Did it generate any, oh, sorry. So the question is about the drop in, observed in IQ points in multiple exposures in the gas trial. Did that get any attention in the media? I'm not sure. I don't think so. Oh, Laszlo knows. Okay.
I can answer that because I was the handling editor of that paper. No, because as Alan pointed out very nicely, there were major confounding in that. And also, it's very nice to read the accompanying editorial of that draws the attention to. So basically, the message of the paper was that we cannot say, despite all the study we've done and everything, we cannot draw any conclusion.
Yeah, that's a great point. The editorial emphasizes that this is a great example of a registry or a study database being used to answer a question it was not designed for. And that is the shortcoming of the GAS trial secondary analysis.
Great, thank you.
Thank you.
One more round of applause for our speakers.